Okay, is my screen visible to everybody?
Yes, it's
Yes.
visible.
Yes.
Excellent. Okay,
Yes.
just make sure that nobody's waiting. Nobody's waiting. Okay, so what we're going to talk about today is the use of lung ultrasound scores specifically for management of neonatal respiratory distress syndrome. So lung ultrasound scores, or what is known as semi-quantitative assessment, or what is also known as functional assessment of the lung, uh, are used in a variety of different contexts. Uh, Respiratory distress syndrome is one of them, but we now also have systems which score in BPD and chronic lung disease, which Dr. Uh, uh, Ojambara will be speaking to us about in quite a bit of detail. In addition, we do, and some centers use lung ultrasound scores in trying to follow transient tachypnea of newborn. There's an overlap sometimes with cases of RDS, and again, the question then becomes how you use lung ultrasound scores in that particular context. And then what I'd say is there's a variety of different conditions that are currently being researched, and in particular, the assessment of heart failure alongside, I would say, PD assessment. So scoring, again, more a kind of, I would say, qualitative assessment as opposed to scoring, which looks at B profiles and progress of B profiles in heart failure is something that I would say is being used for functional assessment. But today, our focus is going to be simply lung ultrasound in the diagnosis and management of respiratory distress syndrome. Now, as we know, the diagnosis respiratory distress syndrome is a clinical radiological diagnosis. And the reason for that is there are significant overlap in a number of differentials that we find in preterm babies. Now, what we know is that respiratory distress syndrome is not just a disease of preterm babies, more common in preterm babies under 32 weeks of gestation, where there is what we typically call hyaline membrane disease. But it's well recognized that surfactant deficiency can exist in a variety of lung conditions, in group B streptococcal sepsis and pneumonia. It can even be part of transient tachypnea of newborn, cases which are quite prolonged, especially if there is a spectrum where a baby is a 34-week and has had an elective cesarean. And you can find respiratory distress syndrome overlap with other conditions like meconium aspiration. And this is quite an important concept, especially in the near term and the term baby, in that when you look at these babies, you can have an overlap of pathologies that sometimes can prove a diagnostic conundrum. And this is where I would say that it's really important that we first know what and how we're going to diagnose respiratory distress syndrome and differentiate it from the other pathologies, but also keep in mind that we may have an overlap in some of these conditions because of the issue of surfactant inactivation, surfactant deficiency that might be secondary, not primary. Now, if you look at the incidence, respiratory distress syndrome has an incidence of about 93% below 28 weeks of gestation. More importantly, what I would say is, this incidence is probably in babies who've not had steroids. Steroided 28 weeks, the incidence comes down to about 60 to 70%. At 25 weeks, if you've had steroids, the incidence is about 80%. But more importantly, it's a diagnosis that is made radiologically. And classically, what we used to describe on chest X-rays was a ground glass appearance, reticulogranular shadowing, air bronchograms, uh, an element sometimes of what I would say is widespread lung consolidation. And really, in this particular situation, if you were to do certain tests that are described in the literature, one of them is the shake test that we used to do in India, but also measurement of LS ratios in gastric aspirates or amniotic fluid, as has been described in the literature, then you can help diagnose respiratory distress syndrome. What is now coming up in a big way and has taken, I would say, this condition by storm is lung ultrasound, in that the diagnosis of respiratory distress syndrome can be made with a higher sensitivity and specificity if you're using lung ultrasound as compared to chest X-ray. Now, why is this important? This is very important because we know that in near-term babies, you can diagnose respiratory distress syndrome. So, at 34 weeks, the incidence is about 10.5%. Now, really, if there's established severe RDS in a 34-weeker, that baby will benefit from surfactant. as opposed to a baby who might have transient tachypnea of newborn, where you might end up using a very expensive medicine where it's not required. And there is good evidence from Dr. Liu and his colleagues in China. They've been able to reduce the treatment of this group of babies by diagnosing transient tachypnea as opposed to RDS and reduce the surfactant use from 70% down to about 20%. So significant cost savings. The risks of giving surfactant in these bigger babies, there's pulmonary hemorrhage. Naturally, from our perspective, these babies are going to get better by themselves. So the need to then have to put a tube down to give surfactant is the other aspect that you need to consider in near-term bigger babies who then need an element of sedation. And I think that's really important because a lot of units around the world are currently putting tubes down these big babies without using sedation, which I think is quite unkind. It's just my view. Now, how does lung ultrasound help in the diagnosis of neonatal respiratory distress? Now, we discussed this last week, and really what we kind of spoke about is the importance of the presence of what I would say are consolidations. And typically, what we describe are subpleural consolidation with air bronchograms, uh, static air bronchograms. Uh, but what we also know is that in the early phases, of neonatal respiratory distress syndrome, in particular with, I would say, near-term babies, you can have a dominant B profile. Lung sliding is usually present. It may be diminished. It is very rarely absent. When you have significant atelectasis and the pleural line, there's no air going up to it. That's when you really get a B dash profile. But a confluent B profile with alveolar interstitial syndrome and white lung pattern, as I will show you, are very common when RDS is quite severe. The pleural line is described as being abnormal, usually thick, and pleural effusion seen in about 15 to 20% of cases. But a significant differentiating point is the presence of subpleural consolidations. And if you look at these subpleural consolidations, this is what they look like. Now, again, what you can see is a thick pleural line. Here you can see what is irregular pleural line. This pleural line is thick, this is thin, it's barely established. You've got subpleural consolidations that, definitely, this is about a centimeter. So they exceed 5 millimeters. More importantly, you've got these static air bronchograms, and actually the pleural line is not established because there's a lack of aeration because of these, I would say, subpleural consolidations. Now, this is the hallmark of respiratory distress syndrome. But what we must remember is the pathophysiology. Now, all of us know that RDS of the preterm baby uh, is primary surfactant deficiency. Now, when there is surfactant deficiency, it takes a while for the hyaline membrane to develop. And in the early phases of RDS, I would say even in preterm babies, there is an element of interstitial edema within the lungs. So you may, when you're resuscitating these babies, aerate the lungs and the anterior regions of the lung, if you're ventilating and you're expanding, you might be able to recruit. And if you recruit them, you might not necessarily have subpleural consolidations in the very early phase. And this is one of the points that's been made by people or colleagues who have done studies looking at lung ultrasound scores using the posterior regions, and that they worry that in the early phases we might not find consolidation in the anterolateral areas, and they feel that that might be a significant fallacy. They also talk about the fact that a lot of the early lung ultrasound scores, like Bratz and DiMartino's protocols, didn't actually define subpleural consolidations in a big way. Uh, and atelectasis with consolidation as a severe kind of a score in lung ultrasound, which may underestimate the severity of RDS. Now, the reason I'm mentioning that is because we're going to talk a lot about why and what are the limitations of anterolateral lung ultrasound scores versus comprehensive lung ultrasound scores, which involve the anterolateral and posterior regions. And after that, I'm going to give you what I think at the moment is the clinical bottom line. But again, to summarize, consolidation is the most important feature of RDS that helps us differentiate it from transient tachypnea of the newborn. there's an element of other co morbid conditions that can exist. So you may have RDS, but if you have a preterm baby who's delivering early because there's group B streptococcal infection, we know the lungs are usually affected. And if you have prolonged rupture of membranes, then really, who's to say that that baby can't have infection and RDS at the same time? And that's why I would say you need to be exceedingly careful in situations like this, and that if a baby is not responding to surfactant, and you haven't done a comprehensive lung ultrasound, you may be missing consolidations in the posterior aspects of the lung that may have a fractal sign and may indicate that this baby has a mnemonic kind of a clinical presentation. The argument for people for not doing a comprehensive scan will be that almost all these babies will already be on antibiotics. So the question is, will it really change your management? So I leave that for you to develop your own acumen for as you become more experienced. But what and how do we do lung ultrasound scores? Well, a lung ultrasound score is a semi-quantitative analysis. It basically looks at a score, but more importantly, this score is basically assigned to a morphological appearance of the lung on ultrasound. And as we know, we've defined, the different profiles. So that's A profile 0. That's kind of an A B profile, which has B lines coming in over here and the A lines breaking up. And then classically, what you've got is an AIS appearance with these subpleural consolidations to the point where by the time you reach a score of 3, in Bratt's classification, you basically have no pleural line. You have these static air bronchograms with quite significant deep consolidations, and there's atelectasis here. So actually, you've got a transitioning score which tries to quantify the severity of respiratory distress syndrome. And there is good evidence now from a meta-analysis that's been published by Capasso in 2023 that looks at 7 studies, approximately 600 to 700 preterm babies, which basically shows that lung ultrasound scores can accurately help diagnose RDS when you clinically correlate, but more importantly, can actually predict uh, the and correlate with, I would say, the oxygen requirements of the baby going up, as well as predict the need for surfactant replacement. Now, this is high quality evidence. These are randomized control trials, not one, multiple. Now, I'm going to take a minute because I'm really keen to know from the group. What do you think about the comparison of FiO2 and lung ultrasound scores? Which do you think is more accurate when you're trying to treat a 27-weeker? So let's say you have a 2-hour-old 27-weeker. We're going to have a little bit of a workshop discussion now with everybody. So a 2-hour-old 27-weeker, his FiO2 is 30%. The baby's on CPAP. So do you think FiO2 is more sensitive, or do you think lung ultrasound is better? Anybody?
I think is the ultrasound is better because they have scoring system. If it is score high, it is more severe. Can use it better than the oxygen therapy.
Okay, that's a lovely opinion from Dr. Ashraf, who's clinically using it. What do the others think? I'm really keen. Yeah.
I think ultrasound is a good predictor, so we can detect the RDS earlier before reaching even the 30% oxygen. So we can give the surfactant earlier than this.
Okay. Uh,
I
yeah, go for it, please.
look, I probably means I'm not start means I still am on annual leave, and so I've not started using lung ultrasound routinely. But from the evidence you've presented, and also looking at all the pictures, means FiO2 at best is a predictive factor for how bad the lungs are. It can be very subjective. So I would believe lung ultrasound is more objective way of defining RDS than FiO2.
Okay. Anybody else have any views?
Yeah, I personally feel that in premature babies, even if FiO2 is 30%, but the lung scoring is high, so it is better. We usually give surfactant because what we have seen otherwise the babies later on deteriorate. So I think lung ultrasound is a better prediction for the like giving surfactant.
Okay. I mean, it sounds very unanimous amongst all of you. Uh, I I'm just keen. Does anybody have the opposite view amongst us?
Can I tell?
Well,
Yeah.
Yes, please.
I,
Just introduce yourselves one by one. Yeah.
hey guys, I'm Anne. I'm in Dublin, and I guess the only caveat is I think people have to be trained in lung ultrasound. So the joy of a number simplifies things for maybe people that don't have good training in lung ultrasound.
That's a very, very important point that Anna's made. I think it's quite crucial. It's a skill that needs training, needs time. There are units that still practice elective intubation of babies based on their FiO2 and delivery suite. Again, the question is, would lung ultrasound help that group of babies? Because actually, there's no trial evidence of using lung ultrasound in that group of babies. So,
Can I
and
can I
yeah,
can I suggest? Because I had an experience. I'm working in North Devon district hospital actually. Um, um, I got one came across one baby who records about 30%. It's a near term like 36 weeks, a late preterm baby who records oxygen about 30%, and we struggled to bring down the FiO2 to 21%, and it lasted for about 6 hours. And eventually, because the UK, we had to escalate to the tertiary neonatal team from the district hospital, and we escalated to tertiary neonatal unit, and they were suggesting that because the oxygen requirement is only 30%, no need to give surfactant at the moment. But later the baby deteriorated, and we had to intubate and give surfactant. And in the morning handover, when I was giving the handover to the next team, everybody was questioning, why did you give surfactant? The tertiary neonate has told you not to give. So, but why did you give surfactant? And then I explained that the X-ray is typical. There are some features RDS, but according to the protocol, it's not fitting the criteria. But the baby was deteriorating. So our consultant and I made the decision. But in this case, if I could have done a lung ultrasound, I can better justify that my surfactant. But I had to struggle a lot in the morning handover to make the other team convinced that we require to give the surfactant. So
sure.
that's my opinion.
So fair points. I've got Satish who's raised his hand. Go for it, Satish.
Hi, look. I mean, yes, it's a 27-weeker. You said 30% FiO2. I would like to kind of know more about right from the maternal, fetal, and antenatal factors to see rather than just going by an FiO2 of 30%. Because I think if in my humble opinion, I think just having FiO2 as a guide to give surfactant or not is not necessarily the correct way. I think if this lady had steroids, if there was any POCUS, was there any setup for chorioamnionitis, what is the work of breathing, what is the CO2 clearance, what's the chest x-rays like, then of course, yes, lung ultrasound can help you quantitatively to gather further information to see whether this baby would benefit from surfactant or not. So that would be my take, rather than just having sometimes you have babies in a 40% oxygen, but may settle. Sometimes babies will be less than 30% oxygen, but the work of breathing and other risk factors would push you towards giving surfactant. So I think the 30% rule, I don't know, it's plucked out of air. I'm not
Beautiful.
necessarily.
You're absolutely right. So I think this is the most important point that I wanted to make, that the kind of concept of the European guidelines on RDS talking about the use of an FiO2 of more than 0.3 under 28 weeks and an FiO2 of more than 0.4 after 28 weeks previously has come from the early studies like the COIN trial. Now, these were not randomized controlled trials looking at different cutoffs for FiO2 to determine whether surfactant was necessary. In fact, there are no randomized controlled trials that actually look at FiO2 cutoff as a marker for surfactant need. We have extrapolated data retrospectively from the COIN trial, and I would say from the support study, which basically said, you ended up intubating a significant proportion of CPAP babies, about 75 to 80% of them, quite early on. So, there was a huge argument there. Well, what are the markers. And a rising FiO2 has been used as a marker of worsening respiratory distress. But what we must realize that a rising FiO2 can be caused by a pneumothorax in that situation. It can be caused by elevated pulmonary pressures, and it can be caused by infection. So it is not a specific marker that quantifies severity of RDS alone. And if we wait for FiO2 to go up, it may, from our perspective, delay the treatment of surfactant, and we're going to kind of approach that. I give you the opposite, which is at least 7 randomized control trials that have been used in this meta-analysis that I will present, which is a lot more evidence. There's actually much more. There's lots of other studies that actually show that lung ultrasound may be useful semi-quantitatively in determining when to give the first dose of surfactant, but provided it is used by trained individuals. And the most important other aspect is, when do you perform it? In what context you are interpreting it? And this is crucial, as Satish has mentioned. Is this a steroided 27-weeker who is a girl who has no work of breathing, has very good clearance of CO2, who really, from my perspective, looks pristine, versus an unsteroided 27-weeker boy who's come out with group B strep in the background, who's needed IPPV at birth? Now, they're two different settings. And I think what I'd say is, if you just merely use FiO2 to determine whether you're going to give these two babies surfactant or not, you're doing a disservice to both of them. So what is really important is that we clinically correlate, and the same applies to lung ultrasound. Now, again, what I'd like to kind of emphasize is the scoring system based on morphology over here, as you can see, and the profile. So, 0 correlates with what I'd say is an A profile. 1 is kind of somewhere between an A and a B profile with B lines and some aeration. 2 is a B profile like AIS with very easily visible subpleural consolidations. And 3 basically is the severest form. Now, this is the classical Bratz scoring. There are other scores which actually class grades into 4 and 5 and subclassify this phase of progression between 2 and 3 based on the severity of the atelectasis. And that this is classically described by Pang et al. As a snowflake appearance of RDS. And there's a very nice article that's there as part of your Dropbox, but we will discuss it the next class. How do you classify severity of RDS? But really, once you lose your pleural line and you have atelectasis, there are degrees of this as well. And there are authors who have kind of given 5 classifications and gone for the posterior regions as opposed to just anterolateral scoring. Now, just to kind of give you a feel of how this evolved, we're just going to talk a little bit about the history of lung ultrasound scores. And one of the earliest studies that was done when we kind of were evaluating semi-quantitative analysis was work done by Rosalind Bratt and Nadia Yusuf. And Nadia will be talking to you. She is my mentor and she's trained me. But they did a study to determine the accuracy of lung ultrasound in predicting oxygenation and the need for surfactant administration in neonates under 34 weeks of gestation. As well as looking at individual kind of gestations less than 28 weeks, so kind of doing subgroup analysis. Now, the way they did that was quite interesting, in that how do we determine whether a baby has worsening RDS and take lung ultrasounds to kind of correlate with whether a baby will need surfactant or not? So how do we use a predictive model? And the statistical analysis for that is done using a concept which is called receiver operating characteristic analysis. So really what they would have is a group of individuals who can do lung ultrasound, but who don't necessarily participate in the decision making around whether the baby has clinical RDS and treatment with surfactant. So they did lung ultrasounds at 2 hours and 12 hours. Now, what is important, and coming back to Anne's point, it's crucial. These are people who were trained. So this lung ultrasound was performed by a physician who'd had 2 months of formal training before the study. This training was based on a 2-day course, which I attended. And I can tell you that, the learning curve for doing lung ultrasound it's about 3 months. So doing and accurately interpreting lung ultrasound scores takes a little bit of a learning curve. But really, once they'd taken those lung ultrasound scores, they basically looked at the clinical course the baby took in terms of FiO2, SpO2, diagnosis of respiratory distress syndrome as made clinico-radiologically, and then the clinical need for giving surfactant based on the European guidelines for respiratory distress syndrome. So for babies under 28 weeks, they bailed out with an FiO2 over 0.3. If they were over 28 weeks, they bailed out with a kind of an FiO2 above 0.4. Now, when you look at this curve, what does it basically quantify? It helps to quantify and evaluate babies who have RDS. And really, we know that with severe RDS, naturally, our lung ultrasound scores will be on the higher side. And with milder RDS, based on Rosalind Bratt's kind of classification, as we saw previously, they'll be on the milder side. But once we kind of diagnose it, we will have a sensitivity and specificity where lung ultrasound is diagnosing RDS based on a score versus the clinician diagnosing RDS and giving surfactant. And when you plot it under an ROC analysis curve, it basically helps you work out that sensitivity and specificity. Now, naturally, everybody in the early stages was quite hot on not wanting to miss RDS because you miss out on giving these babies surfactant. So really what they found is that for babies under 34 weeks, they had a high sensitivity and specificity. It's the curve that you will see in brown for capturing babies with RDS. This area under the curve was quite large. Whereas for babies over 34 weeks, the area under the curve is nearly 50% less. Sensitivity, specificity, 50% less. Can anybody tell me why? I'm keen to make this as interactive as possible. Bottle of champagne, if you can tell me. I will post it to you personally. Have a go, guys. Come on. Why do you think the sensitivity and specificity is less under over 34 weeks as opposed to under?
Because the incidence of the RDS in this age group less than the extreme preterm.
Yes, you're right. But so what I'd say is the incidence of RDS goes up as you are more preterm, but more importantly, what I'd say is your differentials, meconium, I would say the risk of TTN, they're much higher because retained lung fluid becomes part of the differential over that. And we know these conditions can actually overlap with RDS. So that's why, over 34 weeks, you have wider differentials that will actually bring the sensitivity and specificity of the lung ultrasound score down. Now, clearly from our perspective, when we then try to work out what treatment thresholds we'll have, I'm just going to have to take my cursor off. You do this by basically plotting the anterolateral region in Bratt's method. And the reason why I'm going to take a little bit of time in explaining this is because this is the method that we teach on the course over here. Now, really what it means is that our classification basically has R1, R2, and it has R3, R4, L1, L2, and L3, L4. Now, the calculation is actually done by basically looking at the profile, morphological profile on lung ultrasound for R1, R2, and really the lateral region, which is a mix of R3, R4, L3, L4. Now, what this study doesn't specify, and that is really important, and I'm emphasizing it here, is that between R3 and R4 and R1 and R2, in bigger babies, you can have differences in aeration between areas. So even in the right upper area, you might have a kind of a double lung point because there's better aeration in an improving baby who has mild RDS. So the question is, what do you interpret the score as? Will it be a 2 or a 1? And my advice would always be clinically correlate, but the severer score is to be taken. But really, the way that Bratt basically worked out the scoring system was to give a score of 0 to 3 based on this appearance for these lung areas. Your maximum score was 18. And really what they found is that if you used a cutoff score of 4, that increased the probability that the baby would have received surfactant from 25% to 72%. So actually, just using a cutoff of 4 on 18 meant that your sensitivity for the diagnosis of RDS was 100%. There's just one very big problem here, is that the specificity is very low. And that would often mean that you might end up treating a large proportion of babies under 34 weeks who might have transient tachypnea newborn, and you might end up over-treating them. So while Bratt's method was able to establish that lung ultrasound is a good diagnostic modality and that lung ultrasound scores can be used to quantify and correlate with the baby's clinical deterioration, oxygen indices, rise in FiO2, and kind of the FiO2 SpO2 ratio is what was worked out in it. Really, it didn't quite quantify what is the most appropriate score for us to act and predict when to give surfactant with. It recommended that further studies be done. Now, it was DiMartino, again, who worked after Rosalind Bratt in 2018, did the same piece of work with Nadia, who basically looked at specifically the same study with a larger group of infants less than 28 weeks, and basically looked at the sensitivity and specificity based on the curves to determine at what cutoff score the sensitivity and specificity met a level that meant that we would be treating babies with predominantly RDS as opposed to babies who might have other differentials. And their study basically showed that a score of more than 8 had a sensitivity of 82%, but a very high specificity of 92%, and kind of was a cutoff level at which babies who, if they had RDS, would be treated appropriately with surfactant. Hopefully using this kind of a score, in their opinion, would prevent treatment unnecessarily with surfactant. Now, the question is, has this been validated in other studies? Because these are both single center studies done in the same unit. Now, the multi-center study was done by Raimondi, and really they came to a very similar kind of a conclusion. More or less what they demonstrated in both and all three of these studies is that actually the use of lung ultrasound scores and its predictive value for RDS, as well as its predictive value for the use of surfactant, is very accurate. And that a cutoff of 9 or above had a sensitivity of about 0.8 with a specificity of about 0.83. Again, very close to the previous study that was done by DiMartino. So the advantage with this is this was, again, a multi-center trial, a very large number of infants enrolled. Again, 50% of these babies had at least one dose of surfactant. And really, we had a lot of preterm babies, 25 to 33 weeks of gestation. So quite a good range, which basically showed that the score is actually valid across the range. So it wasn't as if extremely preterm babies with similar scores behaved any differently as compared to babies who, say, for example, were more mature, which I find quite surprising, really. Because you'd expect with a higher incidence of RDS that you'd have higher scores necessitating earlier intervention by the clinicians. But really, again, this is just another study which basically supports the use of lung ultrasound scoring across gestations for both diagnosis of RDS as well as for treatment with the first dose of surfactant. Now, if I just summarize really what these studies established, well, they established that you can use lung ultrasound to predict surfactant replacement, that actually the majority of them are using anterolateral screening methods. So all these studies basically used anterolateral screening methods, albeit with just slight differences in their definitions of where the probes were kept and how the images were taken and the frequencies. But more importantly, all of them supported an accuracy of approximately 8 or above as a tool to predict the need for surfactant. I think what is very, very important from our perspective is that all these studies looked at lung ultrasounds that were done quite early on, so within 2 hours of age. Now, this is quite important because actually there is good evidence, as per the Cochrane review, which actually shows that if you give surfactant within the first 2 to 3 hours of age, its efficacy and the effect on, I would say, the ability of the baby to manage BPD and be out of oxygen at 30 days is significantly benefited. So there's a huge argument from our perspective in that lung ultrasound might actually help us to administer surfactant in a timely manner, not just treat RDS by diagnosing its severity. I think what I'd also say is there's quite a broad range of, I'd say extremely preterm babies and near-term babies, 25 to 33 weeks, actually 24 weeks in DiMartino's study as well. But I just caution that none of these early studies actually looked at babies under 24 weeks of gestation. And that's because the first two studies by DiMartino and Bratt were done in France and Paris, where they don't resuscitate babies under 24 weeks. In particular, those particular times when these studies were done. So, the applicability below that is something that, I would be an interesting question to ask. Naveen is asking me, have they looked at the short, long-term respiratory outcomes in their infants? They have. For the studies, some of them, there's no difference. So it's not as if they have less BPD or better neurodevelopmental outcomes. But I think the argument would be about the, again, with the advent of LISA and non-invasive surfactant administration, there is a group of babies, even an extremely preterm group, especially in countries like Canada and the States, where you have really good delivery room CPAP, who will get away without the need for surfactant. And really, that's the group of babies where you would want to predict surfactant need quite early on. Because for these babies who then go on to need a tube 8 to 12 hours later, they then have established RDS. So the argument for use of lung ultrasound would actually be to see if you can actually avoid surfactant in the group that might get away with it, but actually give early surfactant to the babies who really need it. Because there's evidence that I'll demonstrate to you that shows that you can predict the need for surfactant much earlier than with an increase in FiO2, which takes much longer. I think the one thing I do want to mention is that these early studies did show that for babies over 34 weeks, other clinical conditions and their overlap means that lung ultrasound might be less reliable. And I would caution that really clinical correlation in this group of babies is quite crucial. We know that there is a study of surfactant use being carried out in babies between 34 and 36 weeks. But really, what is really important is that you're thinking about your differential diagnosis and you're looking at the clinical course these babies take, because actually there's a difference between a baby with a congenital pneumonia who is having perinatal adaptation problems versus an elective cesarean baby who's got established RDS because he's an infant of a diabetic mother and has surfactant deficiency. So I'd say clinical correlation is very, very crucial. It's crucial everywhere, but I think especially in this group of babies. So any questions before I move on? Any doubts, any worries, any questions about the early studies? Okay, we'll move on. So there is now a group of colleagues who basically have done studies, not just in the anterolateral areas, but actually comprehensive studies using the posterior areas of the lung. Now, can anybody explain to me why you would want to do that? When you've already got established studies that actually demonstrate to you that you can diagnose, you can quantify the severity of respiratory distress syndrome. You've got decent evidence that actually it can be used as a kind of a diagnostic tool for the administration of surfactant. Well, why would you want to use the posterior regions then? Because that's a lot of handling, especially for extremely preterm babies. Anybody?
Because we are giving prone ventilation of CPAP nowadays to aerate the posterior lobe of lung.
Okay, so that's a beautiful, beautiful answer. But just to say that going back to Bratt, and as I will talk to you about in the protocol, when you look at Bratt's kind of analysis and her kind of algorithm, for prone babies, rather than taking the anterior areas, they just took the posterior areas and divided them into two. So actually, they didn't shift the baby's supine. So you can use Bratt's technique for lung ultrasound scoring for the posterior upper and the posterior lower and the lateral regions while the baby is prone. So sorted, we can do that. We know that now. So then why do the posterior regions? Anybody else?
Maybe the score would change if we actually do with the posterior areas and not anterior. The scores might vary.
Okay,
If we
that's a good that's a really good answer. Yep. A- Any other
I think
thoughts?
about the gravity in the posterior region will be should be get a time to make it the posterior for the
Okay.
gravity.
So there's a gravity dependent kind of appearance in the posterior regions, especially if the baby is supine. Now, for people who use anterolateral kind of areas to determine the lung ultrasound scores and diagnose RDS, I mean, their argument is that the back's only going to be worse, as Dr. Ashraf is pointing out, because it's dependent, and really you're going to have a lot of interstitial edema at the back. So they argue against the point of why do the back? The handling, it's unnecessary. You get the information. The only challenge from our perspective is that early on in RDS, and especially with the milder cases, for babies, say, who might be steroided 28 to 32 weeks, they may not develop consolidations because you don't have established hyaline membrane disease. But those are babies who may go on to develop hyaline membrane disease later on and may miss the window for surfactant. And there is work that's been done by the Chinese group by Pang, which has demonstrated that a lot of these babies have significant subpleural consolidations visible in the posterior regions that are missed anterolaterally. So in particular, Pang's group, the article is on your library, as well as Rodriguez Fanjul, have used posterior regions to try and quantify lung ultrasound scores, but using a slightly different scoring system. Now, the question from our perspective is, what does the evidence say? Well, there's a very nice study which has been done by Raimondi, which basically looks at the comparison between three lung ultrasound scores, which includes Bratt and Raimondi's kind of protocol, which had anterior and lateral regions. Again, Bratt basically did the anterior superior, anterior inferior, and lateral region. Raimondi kind of did the anterior and lateral regions with, kind of the probes kept at specific places. But Rodriguez did anterolateral and posterior. And actually, when they worked out and did a retrospective study using all three scoring systems in the same group of babies to see whether there would be differences in management or scores and the quantification of the severity of RDS, they found no significant difference for the area under the curve using the ROC methodology. They actually found that you could diagnose equally whether you used Bratt's or Raimondi's score with a cutoff value of more than 8 that we've already discussed, and that if you were using the posterior regions as you were in Rodriguez's score, that a score of more than 10 had a very similar kind of result in terms of which babies would need surfactant replacement. So the differences between the scores were minimal and had no clinical implications. Now, naturally, from our perspective, if that is the case, then why would you want to? And in particular, for the extremely preterm babies, my argument would be that if you're going to move these babies, you want to analyze the posterior regions properly, then that can be a lot of handling, opening of doors, a longer scan, a lot of insensible fluid loss, which can make these babies quite unwell. So really, at the moment, as part of your library, you have all these articles, and I would encourage you to read them. They're all very nice. But really, when you look at all of them, there's one very big problem. Because of the slight differences in methodology and the ROC analysis, they have different cutoffs for the diagnosis of kind of severe RDS necessitating the need for the first dose of surfactant. And that brings us to a major problem. How do we and what do we adopt? Now, this meta-analysis that's been published last year by Capasso basically says that whatever you do it uniformly and ensure that you have good skills with scanning and interpretation. Because actually, if you train properly, then the inter-observer variation between your analysis and interpretation of morphology varies less. And really, in those situations, you're more likely to be better at being able to make a diagnosis. But actually, the risk of using different scoring methodologies in the same unit and getting confused between anterior and posterior regions, it's a recipe for disaster. You're going to land up in a lot of trouble. So if you want to implement a lung ultrasound scoring system in your setup or your unit, level 1, 2, or 3, really what you have to decide from your perspective is what you are going to use in terms of a scoring system, that how you're going to interpret it, how you're going to document those scores, and really that you're going to use uniform standards methods. You're going to use the same probe, same frequency. And this is really important because if you're doing serial scanning, and in particular serial scanning for trying to determine whether you want to give the second dose, it's small things like a change in the probe or the frequency. It might be that you've decided somebody's using 15 and somebody's using 12. That will actually affect your interpretation and can then just result in a lot of confusion and, I would say, unnecessary therapy. Now, this meta-analysis is really nice, and again, it's part of your Dropbox. But basically, what it kind of lays down is that Bratt's method and the anterolateral methods used by DiMartino is the commonest method. It is also amongst all these studies, and I know this slide doesn't read very well, the most commonly adopted method for clinical management amongst units all over the world. Now, again, if you want to use the posterior regions, that's fine. But there is no current evidence, including this meta-analysis, that shows that the use of the posterior regions confers any advantage over just simple anterolateral scanning or using Bratt's methodology for the purposes of trying to score and determine whether a baby will need surfactant therapy or not. I think really what is very important from our perspective is using a standard score. Now, a few things. So where does this cutoff of 9 come from? Anybody? Anybody done a little bit of reading of the chapters? If you're using Bratt's method? So it comes from DiMartino's work, and I would strongly recommend that you read that article. So DiMartino basically did a very large study, about 163 odd babies. 83 of them were extremely preterm, even 24 weekers. And really, what they used was Bratt's method and determined that when they did the area under the curve, this is the slide that I'd like to show, that when you use a score above 8, your sensitivity and specificity are actually the best to try and capture all cases who have RDS and actually exclude babies who might not. So that's where it comes from. It's been validated by work that's been done by Raimondi in their study, following a very similar kind of a scoring system. And really what I'd say is that it's the most common scoring system that's used in units around the world at the moment. There's just one drawback that I'd like to point out to you is that you must always clinically correlate. There is a very big difference between a steroided 26-week girl who has no risk factors for sepsis versus an unsteroided 26-week boy who may have risk factors. And I would say that if you're using a single number like Bratt's scoring with anterolateral scanning in isolation to try and make your interpretation of whether you give surfactant or not, I think that's as dangerous as using FiO2. Because really, these are babies who may behave very differently where there are other factors that might actually make RDS worse in them later on. So please do not lose your clinical judgment because you might have babies who honeymoon to start off with, especially babies who are extremely IUGR. And I would say that you have to be a little bit cautious when you start using lung ultrasound scores. The second caveat that I would like to share with you today is that if you are using and intubating babies, I would say in delivery suite. And I would say that there are lots of units, even in the UK where I work, where CPAP failure is quite high. Distances between the delivery suite and getting onto the neonatal unit is quite far. The incidence of CPAP failure is high enough to warrant that golden hour might mean that, if you want to keep these babies on CPAP, and 95% of them are eventually getting intubated at 3 or 4 hours of age, they're really missing the early window for getting surfactant. So some units will often, decide that actually it's best to intubate and give them surfactant in delivery suite. And none of the studies of lung ultrasound have evaluated lung ultrasound scores in that context. So I would strongly caution you that if you are electively intubating in delivery suite, be very cautious with the use of lung ultrasound scores and interpreting the need for another dose of surfactant. Now, few facts. So if you give a baby surfactant, what do you think happens to the lung ultrasound afterwards? Anybody?
It will improve. It will be a profile.
It takes few hours to improve, not immediately.
Very good. Very good. So what I'd say is that if you've just given surfactant to a baby and you decide to do a lung ultrasound, it's fluid. It will be there in the alveolar spaces. Having a uniform B profile everywhere, from our perspective, will naturally give you what might be an AIS appearance because your lungs are just full of it. So does anybody know how long it takes?
Maybe a 5
4
to 6
hours?
hours.
4
duration.
hours. Who said that 4 hours?
It was me. I don't know if it's right or wrong, but I think it's 4 hours.
You're brilliant. Who is that? Sorry, that's Avinash?
Arif.
Arif, yeah, brilliant, Arif. Yeah, so the work that's been done, and I'll share the paper with you, basically shows that when you give surfactant, it takes about 4 hours for the lung aeration to become apparent. I'd say that, for babies who have surfactant down the right main bronchus, you do a lung ultrasound after 2 hours, you can pretty much see better aeration in the right lung versus the left lung. That's quite apparent. But again, the positive predictive value for the second dose of surfactant is poor. And you might decide that you've done a lung ultrasound score, you have a score of more than 8, it's 11. In a baby who's on CPAP, you decide that you're going to do LISA. Now, if that baby remains in 40-50% oxygen, the question from your perspective is, when would you do the second lung ultrasound? What are your thoughts?
I usually do after 6 hours the second ultrasound
Anybody else?
to see if RDS has improved or no. But if the child is worsening, we can do it early also. But to determine whether we need a second dose or
If you still need oxygen more than 25 or 30, I can make it after 2 hours.
Okay, great. Anna, I've got a colleague from the previous course. Anna, what do you think?
Sorry, Alok. Um, from the studies, there is no prediction to the second dose of surfactants. So there are no studies to determine that.
Very good. Very good. So, there's one study which has been done by Dean Martino, which kind of looks at that, and the kind of sensitivity and specificity are very low. Can I just say to you that if you have a baby who's still in 50% oxygen after your first dose of surfactant, your clinical examination, and this is why I'm asking this question, is absolutely crucial. So a common complication after a baby has surfactant is tube obstruction. A common complication, if it's not back down, is really secretions and a lack of FRC. But more importantly, some of these babies can develop a pneumothorax. And I've been in a situation where a baby, a decision was made to kind of consider a second dose for a baby, where I've done a lung ultrasound, and actually the baby's had a right-sided significant pneumothorax, which ended up needing a drain. So just be aware that this might not be worsening RDS or a lack of response to the first dose. You must clinically examine your baby before you decide to do a repeat lung ultrasound, always. You must clinically examine your baby before you decide to do a lung ultrasound, always. You must clinically examine your baby before you decide to do a lung ultrasound, always. I am repeating that because there are other differentials that might be there in that clinical case, which might become apparent on the lung ultrasound. It might be reduced air entry. It might be that your tube has slipped down the right main bronchus. It might be that surfactant has gone down the right side dominantly because you have a low tube. You might have a collapse consolidation on that particular side. And it might be small interventions like that that you actually pick up because you do a lung ultrasound that you can correct before you decide that a lung ultrasound score is needed to treat this baby with another dose of surfactant. So I cannot emphasize that enough. There are lots of cases that we're going to do on Thursday, obviously, that will help emphasize that point. Alistair has raised a really nice point. If an infant has become cold during installation, should you not wait until you've reached normothermia? Yes. In an ideal world, I would try to get the baby normothermic, and a lot of babies in delivery suite can be quite cold, which means the surfactant doesn't necessarily work. And again, it's that clinical correlation. It's really important that you're looking at the baby holistically, that TABC approach, then doing your lung ultrasound. Any questions about that?
So I have a question about it.
Please.
Yeah, the question now, as in this given scenario, if our clinical examination is not exciting, is unremarkable, should we still go for an ultrasound early, or should wait by the time the next dose is due? Usually we wait 12 hours, don't we, before the second dose?
So that's a really good question. And I'm going to be really honest to say I don't know the answer. And I don't know the answer because there hasn't been enough research to actually look at, from our perspective, the sensitivity and specificity of lung ultrasound to diagnose ongoing RDS and whether it is better than clinico-radiological correlation alone. Do you get what I'm saying? There is good evidence. There is good evidence from the studies. The study that's been done by Rodrigo, which basically shows that lung ultrasound scores are more accurate than FiO2, that they allow earlier prediction for the need for surfactant as compared to FiO2, which rises later on. But actually, once you've given surfactant, when you look at it in that context, there is very little evidence. My advice would be I'd look at the baby, for any baby who has a significant oxygen need. And I do a lung ultrasound. And a simple example that I'll give you, if I've got complete aeration everywhere, my kind of 6-hour ultrasound is well aerated, the subpleural consolidations are less, then really the question that I'm asking myself is, I don't have an explanation, I don't have a pneumothorax. So it's more used as a modality to exclude other problems. The real question that I'll be asking is there something wrong with the baby? What is the CRP? Is there sepsis in the background?
Yeah.
There's something else that I want to discuss, but I'll discuss it after I show you a case now. But really, from my perspective, the context has to be clinical. Again, if I kind of decide that I'm going to do a lung ultrasound because the baby's in 60, 70% an hour later, and I get complete whiteouts in both lungs, again, the question is why? Is that just lungs that are full of surfactant? Have I got an obstructed tube? So again, it's really, is this a baby who's recessing against the ventilator? So really, is the airway the problem here because the tube is partially obstructed with surfactant? The real question you have to ask yourself is sticking to that approach and then interpreting your lung ultrasound in clinical context as to when you do it. So I wouldn't do it if my baby's back down in air and clinically better. Why should I?
Yeah, true.
Get what I'm saying? It's
Yeah,
unnecessary handling. But
yeah.
really, the reason for repeating it would be a baby who's not improving. And it is doing it because really, if I find that my anterior lungs are well aerated, I'm going to do a comprehensive posterior scan. And in the posterior scan, if I see a massive consolidation with a fractal sign, then I know this baby's got a pneumonia. And, I'm giving you a simple case that I've had recently. Of a baby born at 25 weeks who had surfactant, has beautiful lung ultrasound. And on day 3, this baby goes into 30% FiO2, 60% FiO2 by lunchtime at about 70 hours of age. And basically, a repeat ultrasound shows a right-sided mnemonic consolidation, right upper lobe, with a fractal sign. I do a CRP, it's 10. So clearly this baby has got an evolving pneumonia. And so small things like that. So it might be, it's the way the baby clinically responds and progresses that will determine when you want to do your lung ultrasound.
Yeah.
Does that
Yeah.
help?
Yeah, definitely. I mean, if we find something like you said, consolidation, if we go only clinically, then we may give another dose of surfactant, which may cause more harm instead of improving. Yeah.
Okay, let's give you a little bit of a case. So I'm just going to stop share. I'm just very keen. So to kind of see how much of this you remember. So we're going to borrow this just for a sec. Any questions while I'm just preparing the case? No questions?
While I doing lateral view, I can raise the hand. I make just كده view in the posterior segment. Look كده rapidly
Yeah,
to see what happened going on in the posterior
you
segment.
can look at the posterior axillary line, and you can look at the posterior segments very rapidly. And I don't want to dissuade anybody from wanting to use extended scores. I know that some of my colleagues, Mahmood, say for example in Scotland, he likes using the posterior scores. And again, the worry is that you might be missing quite severe atelectasis and consolidation that might underestimate the severity of the RDS. Experience usually says that those babies will be clinically quite unwell. Okay,
Yes.
so I am gonna share a case with you, and we're just gonna practice. Can you see the screen, or can you see the slide with the notes view?
Just a
Notes
slide.
view.
Yeah.
Notes view. Sorry about that. Okay, can you now see the slide?
Yes.
Okay, so let's see. Alistair, can you hear me?
Yes, I can hear you.
Lovely, Alistair. Beautiful. Can I pick on you today? Is that okay? You have a partner in crime, Satish Somisetti. Is that okay?
Yeah, I'm okay. I'm okay, Alok.
Lovely. So, Alistair and Satish, you have a case. You have a 34-weeker who's an heir. Now, this baby basically was delivered without any need for resuscitation by elective cesarean. The baby is an infant of a diabetic mother, and the mother has had very poorly controlled diabetes. The baby had grunting at birth, was managed with a little bit of PEEP up to about 30 minutes of age. And then a decision was made to admit the baby because the saturations in about 25 to 30% FiO2 were about 88%. The baby just has mild recession, equal air entry, is otherwise looks, pinkish, is well perfused, was admitted, screened, started on antibiotics. And at about 2 hours of age, the baby's on 6 liters of Optiflow. The first gas, which was done at about 60 minutes, was a pH of 7.25 with a CO2 of 50 and a base of -7. So kind of in kPa, kilopascals, that'll be 7.5 kilopascals. The baby's currently in 60% FiO2 and has SATs of 88 to 92%. Is there any other history that you'd like?
Any risk factor for infection, like time of rupture of membranes?
No. So it was an elective cesarean for breech in a 34-weeker. The mother has no risk factors for sepsis. She is not known to have GBS. She's not had pyrexia. Baby's been moving well. Cord gases were normal.
Has she received any antenatal steroids?
No, because currently the evidence for use of antenatal steroids in this group of babies just raises the slight worry that they can have adverse neurodevelopmental outcomes. So our obstetricians decided not to give her any steroids.
Yeah, okay.
Was there any chest X-ray, Alok?
No. So we haven't done a chest X-ray yet. But we did
We
a lung
cold lighted, Alok, to rule out a pneumothorax.
Beautiful, lovely. We did cold light. That's fantastic. So we went through the kind of dope without a tube kind of made sure that the optoflow is attached properly in the nostrils, that it's being delivered appropriately, and that we're in a situation where the pH is okay. The CO2 is 50. Guys, I'm really sorry. I'm just going to take a minute. Is that okay?
Yeah.
Just a minute. That. So any other questions before I move on to the lung ultrasound?
Is there any history of meconium?
No, no history of meconium. No history of meconium, no history of rupture of membranes, no leaking, no infections, just poorly controlled diabetes.
The sugar in the baby?
It's fine. So on the blood gas, 6.6. Okay, so R1 and R2. Alistair, want to have a go? What do you think?
Looks like an A-line profile to me.
Beautiful. You're absolutely right. So just again, our protocol is batwing sign. So how many intercostal spaces?
3 to 4.
Very good. So 3 to 4 intercostal spaces with, what about pleura? Moving?
Yes, pleuros.
Okay, lovely. So kind of, you got these comet tails, any B-lines?
No, not seen.
Okay, what's this? Anybody?
Thymus.
Thymus.
Yeah, it's thymus. So basically, in terms of kind of exposure down to 4 centimeters, a nice, smooth, regular pleural line with comet tails, some A lines, classical A profile. Normal, abnormal?
Normal.
Beautiful. Okay. Now, can anybody comment on the quality of this image, please?
There is dropout at the lower area.
Very good. Very good. So what kind of a frequency do you think I'm using?
You're using a higher frequency, Alok.
You're right. I'm using a higher frequency, and that's why I'm getting such nice, I would say, pleural line. I'm seeing some really nice comet tails, but I'm losing the deeper part of the lung. So just this is an example of image optimization using my GE machine. So now what I've done is just for R2, I've actually reduced the frequency. You can see the liver coming up over here. I've got pleural line. I've got these comet tails, but can you see, I can see A-line profile right to the bottom. And the only other thing that I've done is I've taken my, basically, my gain settings, I've changed them a little bit, just to image optimize. Is there anything else that anybody wants to comment on?
What's
Do you think
this below the thymus? Like
this area here?
yeah. This area.
My gut feeling is it's just deeper tissue.
Okay.
It's not lung. Do you think there's a pleural effusion?
No, I can't see.
Does anybody think there's a pleural effusion?
Thin rim of
First picture, very little we can see.
Yeah, there is a thin rim.
Yeah.
You can differentiate, I suppose. Could be effusion.
Okay, so this is really important. This is the capsule of the thymus. I don't want you to get confused. Okay. Now, people sometimes think that's a pleural effusion. It's not. It's just soft tissue pleura interface. But if you're confused and you want to see, what can you do? Anybody?
M mode.
Beautiful. So do the M mode and look for sinusoid sign. And if you can see a sinusoid sign, then really you've got a pleural effusion. Okay. So we're going to do the M mode soon. So we'll be able to have a look. But what do we think about R2? Normal, abnormal? Satish?
Normal.
Okay. So an A profile?
Yeah.
Okay. So again, in terms of kind of trying to score it, this is our lung ultrasound scoring at the bottom. So how would you score this?
0, 0 now.
Beautiful. So R1, R2, 0. Just, this is, again, it's the same image, but just with image optimization. I'm just showing you slightly better. So the difference here is on the left side, I'm using what is a frequency that's gradually going down. The frequency that I was using earlier was about 12. It's 10 over here and it's 9 over here. So you can just see the differences in the images that as they come across. Now, just for all practical purposes, I would say that I did R34 and it was exactly the same. So the score on the right side is 0. Okay. What about the left side? Let's have a look.
Left side looks like more like a double lung point.
Very good. So again, always stick to protocol. Batwing sign, intercostal spaces, 1, 2, 3, 4, 4 rib spaces. Pleura, anybody sliding? Not sliding.
Sliding.
Yeah, you can see lots of comet tails here that are sliding. And then what you can see is this large area that basically is a B profile on this side at the bottom. So really there is a double lung point here. Okay, this is L1. What about L2? Let's have a look at L2.
L2 also has a similar picture where batwing sign is present, and we can see 3 to 4 intercostal spaces. The pleural line is sliding.
Yeah.
And in the lower area, we can see B profile.
Yeah.
In the upper area, there's A profile. So again, it is a double lung point.
Yeah. Okay. So kind of right lung is better than left lung.
Yeah. Yeah.
Okay.
Yes.
Now this is the lateral view. This is actually L3. What do we think?
L3 looks better than L1 and L2.
Yeah. So it's an A profile. Good sliding. So batwing sign, 3 intercostal spaces. Again, you can see good regular pleura, few comet tails, no B lines, and you can see the classical bamboo sign all the way to the bottom, you know, up to 3.5, 4 centimeters. And really, when I look at, so one of the things, obviously, from my perspective is just looking at the M mode, you've got a classical seashore sign, good movement over there. So how would you score them? So if you had to score them, what would you score L1, L2?
It's 1, isn't it?
1.
1.
Yeah, okay. What about L3?
L3 will be 0.
Okay, beautiful. So when you score the right side, the score is 0.
Yeah.
When you score the left side, the score is 2.
2. Yeah.
Okay. So, I mean, this baby doesn't have much going for RDS, and he certainly shouldn't need surfactant based on BRAT scoring. You happy with that?
No need for surfactant according to the
No.
scoring.
No need. No.
Okay, is this RDS?
No.
No.
Okay, so why is he in 60% FiO2?
So it's either, I'm thinking of one of two things. Either 6 liters per minute is a bit high and he is on the over-distended zone right now. So again, we'll be having some form of decreased lung compliance. And the next step would be pneumothorax. And this is why his CO2 is a bit high. Or the second thing is that we should examine this baby comprehensively and we do posterior lung scans to be sure what is going on.
Very good. So this is beautiful. Marwa, my absolute compliments. If you can't find anything in the anterolateral region that explains this, you have to do a comprehensive scan. You have to look at all other regions. So we did a comprehensive scan, and they were exactly the same. The right is A profile everywhere, lung sliding everywhere, seashore sign everywhere. I've done the left side, and the left side, surprisingly, the back of the lungs were very well aerated. Other than a double lung point in L5, the L6 region, as per the L3 region, L4 region, it's well aerated.
So as is a patient diabetic mother, should I ask for the echo?
Well done. So that is the most important thing from our perspective, is that we basically have what is, for a baby who has minimal respiratory distress, a lung that's probably transitioning, we need to look for other causes. So we did an echo for this baby, and really what we had was elevated pulmonary pressures. We had a significant TR with a bidirectional shunt across the duct, predominantly right to left. So kind of a persistent fetal circulation. We also had a little bit of hypertrophic cardiomyopathy. So really this is delayed perinatal adaptation. And again, it's to kind of say that it's really easy for us to kind of try and use Bratt's score and kind of the morphological methods for trying to diagnose RDS and determine whether a baby in 60% with this history, again, clinical correlation, very high risk of RDS because it's an infant of a diabetic mother with this poorly controlled diabetes. There's a mild respiratory acidosis. But in this particular situation, actually, the lung ultrasound tells you that there's nothing wrong with the lungs. So then you have to think of other causes. Do an echo. Is the sepsis? Is the baby on antibiotics? So very simple case. So what I'm going to do is basically summarize that I will be sharing with you a protocol which will go into the Dropbox, and I will share it on the WhatsApp tomorrow. But more importantly, on the coming Thursday, we will have a workshop, cases to discuss. We'll have peer review as well. And from our perspective, what we'll be getting you to do is doing lung ultrasound scoring, both the anterior and the lateral kind of BRAT scoring alone. If you, does any of you use posterior scoring? Dr. Ashraf, do you use posterior zone scoring?
Yes, sometime because sometime I'm used. And if it is found the posterior segment more atelectasis, can I use this because the severity more it will be increasing than the anterior score.
So the one thing that I think Dr. Ashraf is right about is that if you have a baby who's not saturating and you have significant RDS, the posterior zones might need more recruitment. And atelectasis, and towards the end of the course, we'll be talking about patterns that basically help guide you with lung recruitment on the ventilator. What's been described in the literature is classically the S pattern. Any questions about today?
Dr. Alok,
Yeah.
is the scoring for the posterolateral different or the same? 18
it's exactly the same score. So you use Bratt's score with the baby prone, and what you're doing is you're doing R5, R6, L5, L6, the lateral zones. Now it's a very large area. So my advice would be that I usually scan the entire area laterally, and I take the worst score, the worst score.
Yes, that's what happened.
And what is the extended score you were like talking about?
So the extended score there's a score that's been developed by Zemansky. I'll talk about it next time, when we look at the cases. But there's a score by Zemansky. There's a score by Fanjul. These are the two posterior scores, and again, a lung ultrasound score by Pang. These are the three regions studies that have used comprehensive or posterior lung ultrasound scores. I don't, in my clinical practice, feel that they give a significant amount of benefit in determining the first dose of surfactant. But where comprehensive scanning is important is if your baby is not improving and you really want to look for lung atelectasis at the back end recruitment. So, I have colleagues who disagree with that approach, and it'll be very interesting to speak to Nadia. Nadia will be presenting a little bit more. She's an expert. So again, when you have the expert speaker sessions, we can ask her the question as well. Any other questions?
Look,
yeah.
Would you mind just showing once again how does air bronchogram looks like in ultrasound?
Can I show you on Thursday? I'll have to open
sure.
a different presentation. So I will make it a point to show you on Thursday.
Okay, thank
We'll
you.
go through all the different bronchograms: fluid, air, static, dynamic, everything.
Sure, thank you. Thank you.
Is there anything else that anybody else wants to see that they feel they haven't seen? Okay, that's really kind. Yeah, yeah,
One question.
yeah.
Like in one of the scan when we were discussing, there was the deeper tissues were not seen. So like you asked to decrease the frequency, means we have to change the probe.
No, no,
There are
no,
no
no, 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 no. Your probes will have
Yeah.
variable frequencies. So the probe that we commonly use is the linear or the hockey stick. But if you're using a curvilinear probe, and Dr. Babin Seva is going to share some cases with us on Thursday, I strongly recommend that you don't miss Thursday's session, where she uses a curvilinear probe and her images are absolutely amazing. But really what I'd say is that for a linear probe, you'll have a range of frequencies. So really what I'd say is your default frequency depends on your system. My probe defaults to 12. So naturally, if it defaults to 12, I'll see the superficial areas better, as is seen here. So the deeper area is completely gone. So really what I'm going to do is just drop my frequencies so that I can see A lines deeper down. But in some machines, you can't do that. And you have to work on the focus. So the focus will be at the pleural margin, but you might have to change your focus and bring it down. And that means you might have to capture 2 images.
Okay, in Sonosite there is no adjustment for the focus.
There's no need. So what I'd say is the Sonosite, like the GE, basically auto optimizes. Can you see how the GE over here? I mean, I'd just like to show you this image. So can you see here the image intensity? It's uniform throughout. It's not as if the A lines are getting attenuated. And that's the beauty of using the GE machine, that the focus is auto optimized at every level. Again, what I'd say is that we don't necessarily need to alter the focus here because the focus is auto optimized at every depth. It might be at the compromise of resolution. So what you can see is that the resolution with the image on the left, because I'm using a higher frequency superficially, is much better. But because I've lowered the frequency here, I can see deeper tissue, but my resolution is less. There's a little bit more of a speckled appearance. So really what I'd say is don't worry about that. It's about your ability to make interpretation. Having seen your last images, your last few images, my only worry is that you're losing your deeper portions. So really, I would say if you can reduce your frequency a little bit, that'll help. If you can't, then get somebody, one of your techs, to come and give you a hand.
Okay.
Okay. Time for one last question. Okay, thank you, everybody. I'm really grateful. We're looking forward to the session on Thursday. Have a good evening.
Thank you.
Thank you, Dr. Alok.
Thank you very much. Bye.
Thank you. Thank you.
Thanks, Alok. Thank you.
Thanks. Bye.
Thank you.